For our video assignment, we chose arthroscopy of the temporomandibular joint. Arthroscopy is used to treat and diagnose temporomandibular joint disorders. In our video, we will be discussing a few points regarding the TMJ and arthroscopy of this joint. So first we'll start with the TMJ joint anatomy, which will be explained by Jock and myself, Danielle. Then we will go into the indications for this procedure, which is discussed by Francis, as well as the general risks. And after that, Joshua will be going through the benefits of arthroscopy. Following that, Jock will speak on the different approaches to arthroscopy.
Hello, I'm Jock Cat, and today I'm going to walk you through the anatomy of the temporomandibular joint, commonly called the TMJ, and explain the main surgical techniques used to remove scar tissue. By the end of this video, you understand what structures are involved and how minimally invasive and open procedures work to restore painless jaw function. First, we're going to go over a general overview of the anatomy of the TMJ. Okay, so the TMJ is formed by the rounded head of the lower jawbone, called the mandibular condyle, fitting into the socket of your skull, the glenoid fossa. During normal movement, the condyle both rotates and glides along the articular eminence. In this clinical model here, we can see the mandible, and then on top of the mandible over here, we can see the mandibular condyle. In here, we can see the glenoid fossa, and over here we will have the articular eminence. Between these two bones lies a biconcave fibrocartilage disc. Think of it as a shock-absorbing cushion. It divides the joint into two chambers. The lower chamber allows for simple hinge motion, and the upper chamber allows the jaw to slide forward. In this model, we can add the layers to show you these structures. Over here we have your articular disc, which is a biconcave structure. Over here we have your cartilage, which articulates with this biconcave disc. The whole joint is wrapped in a fibrous capsule and reinforced by ligaments. The main one is the lateral ligament, which prevents the jaw from slipping backwards. Your chewing muscles are the masseter muscles, temporalis, and the two heads of the lateral pterygoid. They drive these movements. With regards to the ligaments, on this model we can show them to you over here. So here we have your temporomandibular ligament, which is your lateral ligament. It limits rotation of the condyle during the opening of the mouth. Over here we have your right stylomandibular ligament. It is a deep band of cervical fascia which inserts between the masseter and the medial pterygoids. It functions to limit protrusion, and it draws the disc posteriorly during mouth closing. If we rotate this model slightly, we can see over here your right sphenomandibular ligament. It is continuous with the disc medially, and it prevents excessive forward translation of the jaw. Moving on to the muscles. Over here we have your right posterior belly of the digastric muscle. This muscle functions in mandibular depression. And inside over here we've got your medial pterygoid muscles, which is split into your inferior lateral pterygoid, so this is your inferior lateral pterygoid, which functions in mandibular depression. On top over here we have your right superior lateral pterygoid, which functions in mandibular elevation. Rotating to the back view of this model, we have your right deep head of your medial pterygoid, which functions in mandibular elevation. when we add on to this model, we can see your masseter muscle. The masseter muscle is one of the larger muscles of your TMJ, which functions in mandibular elevation. Zooming out, we have one of the largest muscles that functions in the TMJ. It functions to elevate the mandible. Now, we have combination movements that are happening in the TMJ. The first combination of muscles produce mandibular protrusion. This is your masseter, your medial pterygoids, your lateral pterygoids, and they function bilaterally to create this mandibular protrusion. Now, when you're looking at the temporalis, your digastric muscles, and your suprahyoid muscles, these function to pull the jaw back in mandibular retrusion. Your medial pterygoids also function to laterally deviate the jaw towards the opposite side, and your temporalis also functions to laterally deviate the jaw, but it does it towards the same side.
The temporomandibular joint is a synovial joint. In this picture, we can see the head of the mandible, which articulates with the temporal bone on both sides. Each joint includes the mandibular condyle, the articular eminence of the temporal bone, and an intra-articular disc between them. This disc divides the joint into two parts. The lower joint is a hinge joint between the condyle and the inferior surface of the disc, and the upper joint is a gliding joint between the articular eminence and the superior surface of the disc. The articular surfaces are covered by fibrocartilage, which can repair and remodel, unlike hyaline cartilage found in most other synovial joints.
The American Association of Oral and Maxillofacial Surgery recognize that there's 5 main indications for arthroscopy of the temporomandibular joint. The first one is internal derangement, so it's Wilker's stages 1, 2, and 3, and we will put a picture in the slides to show the different classifications. Then it's degenerative joint disease, synovitis, recurrent dislocation, and hypermobility due to intra-articular adhesions. There are other indications as well, other than these main indications. Other indications include patients that still have constant jaw pain even after non-surgical intervention, so they went to see a dentist, they went to see a chiropractor to work on the joint. Another indication is osteoarthritis, tumors, and since arthroscopy is not a very invasive procedure, the surgery also helps to confirm if further surgical intervention is needed. Okay, so general risks for the surgery / complications. It's a very low risk procedure, but there are certain complications that can occur. These include temporary paralysis of the facial nerve, usually the zygomatic and the frontal branches. Infection could occur, but there's only a 0.1% chance of infection. You could have pain, edema, and vascular lesions after the surgery. Very rarely there is perforation of the ear canal. Another rare complication is reflex bradycardia. This occurs when something stimulates the body's heart rate to suddenly drop. It's usually a protective mechanism of the body. And intra-articular bleeding is a more common complication. Cold irrigation usually helps for this, and this helps to induce vasoconstriction.
Benefits of TMJ arthroscopy. Minimally invasive approach. TMJ arthroscopy only requires a small incision. This leads to reduced tissue trauma, resulting in less post-operative pain, as well as quicker recovery in comparison to open joint surgeries. Effective treatment for specific conditions. Arthroscopy of the TMJ has been shown to be successful in addressing conditions such as synovial chondromatosis with skull-base perforation. Potential for tissue regeneration. Research from the Massachusetts General Hospital has shown that the use of diatom nanoparticles in combination with TMJ arthroscopy was successful in promoting intra-articular regeneration. The aim of this approach was to enhance the joint's natural healing processes, offering potential benefits for patients with osteoarthritis. Diagnostic capability. TMJ arthroscopy allows for direct visualization of the joint space, enabling accurate diagnosis of intra-articular pathologies. Reduced risk of complications. In comparison to open joint surgeries, arthroscopy is seen to have a lower risk of complications, such as infections and joint stiffness. This is due to its less invasive nature. Improved jaw function. The TMJ arthroscopy aims to enhance the jaw's mobility by increasing the maximal mouth opening. Studies have shown that following the arthroscopy, there is better functional outcomes for patients.
In this section, we're going to be going over the different surgical techniques. The first of which is going to be atherocentesis. As you can see on screen, we have a 3D animation of an atherocentesis. Atherocentesis is the simplest approach. Under local anesthesia, 2 needles are placed into the upper joint space, as you can see over here, and then saline is flushed through to break up the early adhesions and wash out the inflammatory debris. It is quick and often done in the clinic and helps when scarring is mild. The next procedure we have here is arthroscopic lysis and lavage. On screen here we have another 3D reconstructed model of this procedure. And an arthroscopic lysis and lavage uses a tiny camera and 2 instruments through 1 or 2 small portals. You can directly see the scar tissue, mechanically cut it out, and then irrigate the area. Recovery is usually fast, and most patients are back to normal within a week or 2. The last surgical intervention we'll be discussing today is called open arthroplasty. In most advanced cases such as bony ankylosis, recurrent scarring, advanced osteoarthritis of the joint, an open arthroplasty may be performed. This can involve removing a part of the condyle, which is called a gap arthroplasty, or you can excise the damaged disc. And in this reconstruction, we're going to be showing you a placement of a synthetic spacer, or otherwise known as a stock implant, which is affixed to the temporal bone that provides a reconstructed articulating surface for the condylar head. In this area you can see there is issues with the articulation at the TMJ. They place the spacer with the prosthesis, and it allows for better articulation on these 2 joint surfaces.
This animated image shows a patient different exercises to relieve jaw pain, and these can also be used as rehab exercises after a joint arthroscopy, specifically for the temporomandibular joint. In this video, the patient is using a TheraBite device to help with demonstration of TMJ rehabilitation following surgery. So here you can see how the patient begins with passive mouth opening, and the device is used to gently stretch the jaw and improve the range of motion. Then, controlled repetitions of opening and closing is performed, which helps to reduce the stiffness and maintain mobility of the joint. The TheraBite tool allows for a safe, pain-free movement, making it ideal for the early recovery stages after surgery. By doing these exercises, it helps the patient to restore jaw function, prevent post-surgical adhesions to the joint, and reduce muscle tightness.